Thank you very much for this kind of invitation to participate in this distant congress, but I hope that it will be successful in any case. The topic assigned to me was, why do we need opioids to treat your pain? We know that most of cancer patients develop pain during the course of their disease, particularly during the last week of their life. But severe pain requires absolutely a proper management. That means that we need expert people to treat our patient, particularly when using opioids to optimize the responses. Unfortunately, most of this pain is not managed by palliative care physician or expert physician through the desirable, but really relies on integration and referred belated. I will show a typical case in which this is possible. For example, in my unit, this is a patient with cancer of the colon just after the diagnosis of pancreatic pain. He was admitted first in our unit because he had uncontrolled pain. And he also had other problems, including, for example, jaundice, anorexia, fatigue, emotional distress. The patient was particularly distressed. So the first step was rapid control, pain control with intravenous morphine titration, achieving an effective dose of 40 milligrams converted to the oral routes. But at the same time, we tried to control symptoms, including anxiety, insomnia, and fatigue, and anorexia too in these patients. Then we have an interaction with our oncologist for a good prognosis and treatment. After achieving all these things, and then after placing a stent on the biliary tract, the patient was ready to start his treatment with the chemo. After achieving a good symptom control, after good counseling with the caregiver. This is very important to work all together. Because someone can say, why should we not use opioid for cancer pain? I would like to introduce this concept in respect to the title assigned, because the skilled use of opioids is crucial in the relief of pain. But unfortunately, we don't have a big evidence for this information. But we know that it is difficult to achieve evidence in such kind of a patient. Otherwise, we should compare patient treated with opioids, for example, and patient treated with placebo. I think that this is unreliable, is not ethical for our patient, because we know that opioids act as an analgesics. And this is a very, very old study performed at home, in which we had a good control in most of our patients, followed at home with a few drugs, with a few facilities, such as in patients followed at home. But nevertheless, it was possible to have a good pain control using opioids at home, not in specialized centers. But someone can say, okay, other drugs may work better. And this is a strange paper. It is a scandal from a scientific point of view, in my opinion, because they made a comparative efficacy using a Bayesian network meta-analysis. That means to introduce all the data all together and then say, okay, this is effective or not. But the conclusions are completely wrong, because they suggest that some non-opioid analgesic or anti-inflammatory drugs can serve as effectively as opioids in managing chronic cancer pain. And this is really, really strange, because this was published in a big journal, in Journal of Clinical Oncology. But at the end, authors want to conclude that opioids are not necessary for chronic pain. You need just lidocaine, you need just anti-inflammatory drugs, you need just codeine, or for example, ziconotide by spinal root. Very, very stupid papers, but unfortunately published in a big journal, read by many, many oncologists. But as I mentioned in this editorial, reviewing without a clinical background is detrimental for cancer pain management. All these authors never published a clinical paper on cancer pain. So this is what I call it the Copernican revolution, in which wrong acquisition and interpretation of data without the knowledge of drugs may be very, very, very dangerous. Because they include, for example, in this category, also ziconotide, that is a drug that is used intrathecally. And they omitted that in this paper, for example, patients were receiving high doses of opioids, antidepressant, anxiolytics, anticonvulsants, and many, many anti-inflammatory agents. So how can say that ziconotide works as a spinal administration? That is a very strange indication for all our patients. This is just propaganda. It's a stupid question posed and resolved by scientists who never seen patients. And this is really worrying because oncologists may read this information and can say, okay, this is evidence. This is a fake news. Is misleading information. This is unfortunately available to the oncologists. So they know that this information is false, is exactly a fake. And I invite you and all the oncologists living in Argentina to avoid this kind of literature. But someone may say also opioids may produce addiction. In some way, it's true, but it's also false, because if you use opioids properly in a cancer patient, the risk is minimal. And I will show some information for that. Another thing is the use of opioids for non-medical opioid use. In this case, of course, the opioids may be dangerous because they are not monitored. Absolutely. And the story starts with the postoperative pain, in which patients are prescribed opioids for a prolonged period of time, and they may get addicted for this reason, not for a proper use of opioids. And you know the story of the USA crisis. It's a strange crisis because in Italy and many European countries, we are not able to see these events in which patients may use opioids without any prescription, without any control, and so on. It's a different health system, probably. But I have to also to distinguish what is the physical dependence, what is the pseudo-addiction, that is an iatrogenic syndrome. What is the chemical coping? This is more frequent to be observed. And what is addiction? That is an aberrant use characterized by loss of control, craving, compulsive use and preoccupation, and continuous use despite harm. It's really rare to observe this kind of condition in our patients who are normally monitored. We are normally prescribed opioids. We are commonly seen continuously in our setting. And someone also tried to invent the so-called opioid-free anesthesia. That is for the same reason, because opioids are improperly used in the post-operative period. Someone proposed to eliminate opioids from the perioperative setting. Is another strange thing, because opioids have to be used in proper doses, of course, and with appropriate post-operative care, not exactly like exactly as it is used in USA. In our unit, I run 2 units: anesthesia and intensive care, the hospice, and the acute palliative care. In our experience, in more than 400,000 anesthetics, no patient was prescribed or misused opioids after discharge, unless for patients with the cancer pain, of course, in which they followed a different setting. No patient after anesthesia developed aberrant behavior. What happened in the cancer patients in USA, for example, in which they, some colleagues in Houston evaluate the risk of aberrant use. And they found in a lot of patients that many patients were SOAP positive. That means SOAP is a tool used to monitor the risk, not the behavior, but the risk. And the risk do not correspond to real proof of developing aberrant behavior. In any case, the risk in USA was really, really high, and was correlated to the gender, was correlated to pain intensity, anxiety, and financial distress. That's right. But these are the behavior for addicted people. That means addiction of opioids, then those prescribed, forget from prescription, salt prescription, and so on. It's difficult to find this aberrant behavior in our patients. And what is important that unfortunately this situation had the consequence, because cancer patients were less treated than before, and the opioid consumption reduced in these last years during the oncological treatment in a significant way. Moreover, cancer patients may have more difficulties in having opioid prescription after a palliative care consultation. These are the consequences of the opioid crisis. But the standard in Europe, as you can see, is that patients should receive tailored multimodal treatment. The patient should be referred for more specialistic advice in patients with a difficult condition. The pain management should be reviewed regularly to assess outcomes. And again, healthcare professionals who treat patients with cancer should receive ongoing education and training. This is standards for the management of cancer pain in Europe. This is a position paper of a group of experts. But Europe is facing the same opioid crisis that we had in the United States. Probably not, because Europe as a whole is not facing the same crisis. And the discussion on the potential harms of opioids should not obstruct, should not impede opioid medicine for cancer therapy and palliative care. I don't know what is the situation in Argentina. I think that we had some problems with the low opioid prescription rather than with high opioid prescription observed in Canada, United States, in UK, and the Northern European countries. In Italy, we have a poor opioid consumption. And we wanted to explore what is the situation in Italy, assessing the aberrant opioid use in advanced cancer patients. This paper is going to be published despite the risk, because there are some patients who had some risk using the SOAP tool or the opioid risk tool, but as you can see, no patient developed an aberrant behavior in terms of opioids use. So there's the risk, but if the patient is monitored, there's no absolutely development of aberrant abuse. The problem is who will follow these patients. And the misuse we observed in our activity is very, very limited. Only 5 patients after thousands and thousands of patients. And this was chemical coping, not addiction. Patients received particularly fentanyl products because they felt a sense of depression or anxiety, so they mitigate their symptoms with the use of opioids. That means that there is a chemical coping. So we need to educate patient and the family to provide a supportive environment to prevent dose escalation with appropriate treatment, with the proper selection of opioids, eventually switching opioids, and also rule out psychiatrics such as affective and psychosis. These patients are worthwhile a good monitoring, a special monitoring, because are at risk. There are patients with cancer receiving opioid therapy. We need universal screening, yes, of course, but most of them will not develop any aberrant behavior if they are regularly monitored and they are regularly followed by palliative care expert, physician or pain therapist, someone who is expert in the use of opioids. The strategy, if you have the risk, if you have the patient who present the risk and eventually also aberrant behavior, of course, the secret is again continuous monitoring and develop, implement and management strategy to avoid the development of aberrant behavior. So to go back to the title of my presentation, why should we not use opioids for cancer pain? Because opioids remain the cornerstone for cancer patient management. Despite the poor evidence, I don't have any alternative, in my opinion. Are drugs may work better? Absolutely not. We can use some drugs to improve the opioid response, to limit adverse effects, to provide analgesia for some clinical condition, but in most cases, severe conditions will require opioids. Opioids will require expertise and a high level of experience. That's true. Patient risk should be monitored, but this should not exclude from any treatment, including opioids, of course. Cancer pain management is a human right, and at the moment, I do no other alternative to opioids. So, opioids remain the cornerstone for cancer pain management. The use requires expertise, patient risk should be monitored, and cancer patient should be properly treated by experts, because the human right to limit suffering in very advanced cancer patients. So I conclude with my thank you again. I hope to come to Argentina next time on the presence. Please consider also this congress that I organize yearly in May in Palermo, simply the best, because the invited speakers are the best. Thank you very much again. Bye-bye.